Open vascular surgery is changing rapidly, and I wanted to give you sort of the benefit of our experience as early adopters, and mostly with flow diversion, which I think is a significant improvement. And so with that introduction, let's talk about the, I don't have any relevant disclosures. I'd like to talk about new flow diversion techniques, unresolved problems, the role of surgery, and future considerations. So, after ISAT was published in 2002, there was a worldwide trend towards endovascular treatment. And America has been no exception. I think it was a little bit later than other countries. But a lot of it is related to the financial capabilities of the country. And this was a great study published by Vladimir Benish some years ago, but mentioned that basically the countries that can afford it are early adopters of endovascular treatment, and those poor countries in Eastern Europe didn't adopt endovascular as quickly for the reasons that Jafar just mentioned. It's interesting, we had a huge revolution of endovascular people that were trained in neurology and neuroradiology in America. And we covered a large segment of the population, or of the geographical area in America, with fairly sparse population. But this is the kind of patient that we would see after this intervention, is that here's a subarachnoid hemorrhage, ACOM aneurysm in a 53-year-old man, straightforward lesion, but was treated by an endovascular person in an institution with no neurosurgery in another state. And they spent 5 hours trying to coil this aneurysm, ended up with a coil going up one of the A2s here. And the unfortunate aspect in this patient was this was the only viable circulation. The vertebrals bilaterally were occluded, and he ended up in stroking the entire hemisphere on one side, as well as the cerebellum and posterior fossa. And so it was a simple matter. If you have equipoise and you have surgical ability, this was a simple open operation to do, and we just pulled out the coil and then clipped the aneurysm. So needless to say, there was sort of an over-adoption of endovascular coiling, and we suffered the consequences of this. And I think Dan and a number of people have discussed during this conference already about these recurrences after coiling. And I agree, I don't think coiling should be a treatment for aneurysms these days in the face of flow diversion, especially unruptured aneurysms. So here's a giant aneurysm that was recurring and required a high flow bypass that we took care of many years ago now. But I do think there's been a game changer, and it's flow diversion. And for those of you who are not as familiar with this, I just wanted to give you the benefit. We were very early adopters, and we've got a lot of experience, and I'd like to show you some of the limitations and some of the real successes that we've had. So we've had 20 years or so of intracranial stent placement. First of all, the Neuroform, but more recently, this pipeline stent, which has a smaller interstices, so it directs flow more effectively than the earlier stents that were used for other purposes. So the idea is that you develop stasis in the aneurysm and then essentially thrombosis of the aneurysm, which then resolves over time. I think the real problem that we're facing is that in most cases it requires dual antiplatelet therapy. And so an aneurysm occlusion occurs in a delayed fashion. So for subarachnoid hemorrhage patients, this is a limitation. So this is what it looks like ultrastructurally. It gets incorporated into the wall of the artery, and hopefully the perforators stay open, and I'll talk about that in a moment. But the original FDA approval was based on the PUFS results that was done 10 years ago now. But I just wanted to show you the results that they've been essentially very, very good. There's this hemorrhagic problem that occurs, that are parenchymal bleeds distally that we haven't completely figured out yet. But if you look at the results from many different centers, from different trials, they've been excellent as far as aneurysm occlusion. And I'd like to point out that over time, this is the only treatment where the improvements occur over time. Every other type for aneurysms, there's a chance of recurrence. But if you look at the results here, in most patients, 95% patients, there's complete occlusion. So it's remarkable. and has changed our practice considerably. There's this late aneurysm rupture risk of less than 1%, and then there's this ICH issue, which is unresolved, but occurs in less than 5% of patients. Ischemic stroke, in this range, you can see, it's a little bit less than the neuriform stent registry, but it's 5% usually or less. So in a lot of centers, and including ours, a lot of the unruptured aneurysms now are treated with pipeline stent. And so I'd like to show you, and this is just one small point, that it's actually much cheaper than a coiling because the retreatment rate is so much less and the occlusion rate is higher, and the procedural costs are less actually than coiling because the number of coils that are needed to be treated. So the initial indication was for a very limited segment of the carotid artery. I think Jafar showed a beautiful case where it was used initially, but it's being used much more broadly now in different anatomical areas. So if you look over a large experience now, there's expanding indications, and it's used in different locations, posterior circulation included. Here's a study from our center where we've used it for vertebral aneurysms, very effective, and you get complete remodeling of the artery. It's remarkable. And also for these pica aneurysms that are proximal, they may not be right at the bifurcation, but it reduces the flow enough that aneurysms actually involute there. So it's remarkable. Even though you put the pipeline in the vertebral artery, the pica aneurysm will resolve in most cases. It's completely revolutionized the management of these giant cavernous aneurysms. You know, you just can't compete with this. When you look at this, here's a giant partially thrombosed aneurysm. It was treated with pipeline, and here's the deployment, and here's the artery as it remodels over time. So it's a remarkable, and the aneurysm slowly resolves over time, as was mentioned by Jafar. So it completely revolutionized and replaced this whole notion of high-flow carotid bypass that we spent a lot of our time thinking about when we were young, the Fukushima bypass and all of these bypasses that were developed and refined to try and improve revascularization across the cavernous sinus. So it's made it obsolete. It's also helped with intraoperative injury. Here's a chordoma where the carotid was injured, and there's a pseudoaneurysm now in the vertical segment of the carotid here, and treated with pipeline, and 3 months later, you see complete remodeling of the artery and repair. So I would ask you what you thought would be the best treatment for this aneurysm. Here's somebody that we treated about a month ago, a proximal PCA aneurysm, fusiform. I thought this was very treacherous. It bled basically into the midbrain, very little subarachnoid hemorrhage, but into the midbrain and up into the thalamus. She was densely hemiparetic. But I thought this would be very treacherous clipping. You partially clip it, maybe clip wrap it, but was treated with this new pipeline that has a coating on it now that you're able to reduce the number of antiplatelet agents to just one. So the patient was just placed on aspirin after the pipeline stent. And she's had a very successful course. Here's the deployment of the pipeline across the lesion, and you can see, and she's made a very, very good recovery. So this is evolving very, very quickly. Let me tell you some of the limitations. Some of them are listed here, but I want to show you a few cases. Here's a young man with an ICA blister aneurysm, and I think we're all looking for a better treatment for blister aneurysms, these very treacherous proximal carotid variants where there's basically a hole in the artery. And I used to clip wrap these, and I bypassed them over the years. But here's a deployment of a pipeline. This case was published. Incomplete occlusion of the aneurysm, and the patient went on 10 days later and had a subarachnoid hemorrhage and died. So I think you've got to be careful. This patient had the earlier model of pipeline, and subsequently this has changed practice. And here's a more recent patient where they've put 2 pipelines in and they've shingled them, and so it reduces the amount of interstices and less leak, endo leak, as they say, at the site of the aneurysm. This is a case to remember. This was actually the case, and Kim Nelson was involved with this, where we treated this patient of mine with this giant basilar fusiform aneurysm. And it was enlarging, and the natural history of these is just terrible. But this was the first 5-centimeter pipeline stent placed in a patient in America. And immediately we were happy with this, but I want to point out this endoleak proximally, very dangerous. And this is what they learned very early on in posterior circulation. This endoleak persisted, and she did very well clinically for the first 2 weeks, and then died of a subarachnoid hemorrhage. Okay. Now, subsequently, they've learned that you need to coil beyond the aneurysm for these basilar as well. This was an unusual problem. This is a patient of mine with a giant proximal carotid aneurysm. The patient wanted, this was an unruptured aneurysm, and she had visual loss and wanted to be treated with pipeline stent. So the stent was deployed, but you can see when the aneurysm is very large, there's a lot of pressure put on the stent, and the distal part came out into the aneurysm. And it was effectively like a garden hose going off in the aneurysm. And so you had an angiogram where the pipeline stent was actually just deployed into the aneurysm on the proximal side only. So what I did in this case is I took her to surgery, and we did a bypass, and I'll show you removing the pipeline. So I think this is an important lesson. This was obviously done quite early after the pipeline deployment, but here's the aneurysm. And as I mentioned, they deployed the pipeline. It came out distally. And so what we'll do in this case is we'll perform a bypass, high flow bypass across the aneurysm. I prefer to go from the ECA in the neck. That way I never have to occlude the lenticulostriates and go to the M2 branches. So what we're doing here is I bypass the patient, and we're opening up the aneurysm, and I'm going to remove the pipeline because it was across the ophthalmic artery. And I thought we would lose the ophthalmic if we didn't remove it with no flow through it. So you can see what's happening is as you pull it, it narrows and it pulls out like butter. Very simple, but this was in the first few days after deployment, so before it had time to incorporate it into the wall. So then we'll go ahead and clip the lesion and trap the lesion, thrombectomize, trap the lesion, and then what I did is I clipped the aneurysm proximal to the aneurysm, but left it the ophthalmic artery feeding with the bypass. So I think we're all learning as we're going along with this. So cases to consider, giant aneurysms. I still think we need to do open operation, thrombectomy, remove the tumor in these symptomatic cases. What would you do with this? This is a 37-year-old woman who had this aneurysm that was growing on MRI. And when she had the angiogram, it looked like there was a vessel coming out distally on the aneurysm. Here you can see on the CTA, on the DSA reconstruction. So we'll go ahead and explore this aneurysm, and indeed the angiogram was completely correct in that the distal vessel was coming out from the aneurysm. So what we'll do in this case is we'll revascularize that one vessel by doing an STA anastomosis. I'll go into one of the branches coming off of it so we can leave flow to the other branch during the anastomosis, and then go ahead, do an ICG, make sure it's patent, and then try to reconstruct the aneurysm without that distal vessel involved. So what we can do now is we can dissect out the aneurysm and then go ahead and deploy a clip and reconstruct the middle cerebral trifurcation in this case. So you can imagine that from an endovascular standpoint, it's going to be very difficult to treat this aneurysm. How are you going to make a device that's going to be able to do something like this? So I still think open surgery is very important. Here's another case, a distal anterior cerebral artery aneurysm. And what we'll do in this case is reconstruct the vessel, because it's just too distal. They tried to cannulate it with a small. Is that, I'm out of time? Okay, sorry. So basically, I think then I'll just wind up. Oh, my computer is frozen now. Sorry. By saying that we've got a lot of unresolved issues with pipeline, and we're learning. The field is changing very quickly, and the current literature does not represent what the current technique is, and so it lags behind. And we're still going to need open surgeons, and it's going to be very important for us to keep training people to be able to do these techniques and bypass techniques and complex aneurysms. Thank you very much.